Good day, ladies and gentlemen. Welcome to the first webinar of the Pre-Analytical Masterclass webinar series brought to you by the Asian Pacific Federation for Clinical Biochemistry and Laboratory Medicine, supported by BD. First, allow me to introduce myself. My name is Nadra and I'm from BD. I'll be your moderator for this webinar. Before kicking off the webinar, please allow me to review a few housekeeping rules for this session. This webinar will run for an hour, and certificate links will be emailed to you upon the successful completion of the webinar. Throughout the webinar, you may ask questions via the Ask a Question chat box located at the left lower corner of your screen. Questions will be addressed at the end of the presentations, and questions that were not addressed will be compiled into an FAQ sheet that will be sent to all participants. Should you have any questions after the webinar, please do email them at passoutheastasia@bd.com. Before we start the webinar, I would like to invite Dr. Perlin Teo, the member of the Education Committee from the APFCB, to do an opening speech. Dr. Perlin Teo, please.
Thanks so much, Nadra. Good afternoon, everyone, and welcome to our APFCB Pre-Analytical Masterclass. So this is the second year in a row that APFCB is collaborating with BD to conduct this Pre-Analytical Masterclass webinar series. So for those of you who have attended our last year's Masterclass and are back, so welcome back, and thank you again for your support. So last year, what we did was to really kind of focus on the basics of pre-analytics and build the foundation for everyone. This year in our Encore series, what we are doing is to drill down to advanced topics. So we have today arterial blood gas analysis. Next week will be blood culture pre-analytics. The third week will be phlebotomy training and assessment of competency. And finally, we'll bring back all our three speakers for a roundtable discussion and extended Q&A. So welcome once again, and I'll let Nadra take over for presenting and introducing our speaker today. Nadra, please go ahead.
Thank you, Dr. Perlin. And to kick off the webinar today, I am pleased to introduce our very first speaker, Dr. Ong Lee Chen. Dr. Ong Lee Chen is the head and consultant in Department of Laboratory Medicine of Alexandra Hospital, Singapore, and consultant chemical pathologist at the Department of Laboratory Medicine, National University Hospital, Singapore. She received her medical degree from the NUS and specialized training in internal medicine and laboratory medicine. She is a member of the Royal College of Physicians, United Kingdom, and a fellow of the Royal College of Pathologists, United Kingdom. Dr. Ong will be presenting on specimen collection for arterial blood gas analysis. Dr. Ong, please.
Hi, good afternoon. Thank you so much for the kind introduction, Nadra. I'd like to also thank APFCB and BD for this kind honor to allow me to share this particular pre-analytical interest of mine. Right. So thank you so much. Can I just check that you all can see the slides?
Yes, I think we are live.
Great. Thank you so much. Right. So today, we have quite a bit of content, a bit of history, review, and background basics of acid-base balance, as well as clinical applications. And then we will focus on a bit more about specimen collection for arterial blood gas, as well as specimen transportation conditions, and then followed by a little bit about what is the difference between point-of-care testing versus laboratory testing. So, just as much as we learned a lot from the recent COVID pandemic, right? The polio outbreak in Denmark in 1950s actually led to the invention of the ventilator, as well as the blood gas testing that we know today, right? So this is really something important to point out, right? So in 1952, there was a poliomyelitis outbreak in Copenhagen, and about 3,000 patients were admitted to this hospital then. Right, so we have this new, relatively young anesthesiologist, Dr. Ibsen, who had just returned from a one-year fellowship in Boston, and he adopted his newfound learning from Boston, right, where he learned about manual bagging, positive pressure ventilation, tracheostomy, tube sedation. And together with nurses, medical students, as well as other healthcare professionals, they were able to reduce the mortality or death of bulbar type poliomyelitis from a mortality of 87% to 11%. And that was really through the relationship and the support of their laboratory, because we have Dr. Estrup in the laboratory who helped to derive PCO2 or carbon dioxide gas measurement, all right, with the interpolation of the PCO2 and pH measurement. And that was really together with the use of this pH electrode that was developed recently, just before 1952. And so he was able to help Dr. Ibsten prove that they were able to measure pH and PCO2 in these patients with bulbar poliomyelitis, and able to prove that this patient had acidosis, acidemia, and carbon dioxide retention. And more importantly, they were also able to show that with positive pressure ventilation, manual bagging, they were able to reduce this acidosis. And so this collaboration and setup led to the start of what we know currently as an intensive care unit, which comprises of a multidisciplinary team with internists, with surgeons, with respiratory physicians, nurses, anesthesiologists, and even with laboratory partners as well. Right. So the history of traditional blood gas testing refers to measurement of the partial pressure of some of these physiologically active gases in our blood, right? Your oxygen, your carbon dioxide, the blood pH, and oxygen saturation of hemoglobin. So the methods for measuring PCO2 and PO2 were first described by Van Slyke in 1924. And then 1950s, we have the Astrup apparatus, which was what we went through earlier. And the very first blood gas analyzer where you can have measurement of pH, PO2, and PCO2 in one consolidated analyzer. This was in 1958 or 1959 by Severnhaus and Bradley, as you can see in this picture here. So it was a very big, chunky device, and still it was really something of importance at that point in time. Right. Then we move on to current blood gas apparatus are really much smaller, automated, expensive, and in the hands of clinical pathologists rather than our pulmonologists, anesthesiologists, and critical care physicians. The other importance about current blood gas analysis is that it's more than just gases. We have expansion of test menu where we can measure your lactate, your metabolites, so lactate and glucose in patients where we're trying to get them out of sepsis and severe critical ill condition. We can measure electrolytes, sodium, potassium, your ionized calcium, and even ionized magnesium in some cases. We can measure the hemoglobin and hematocrit in these patients who are in critical care. We can measure the co-oximetry, including methemoglobin, carboxyhemoglobin. And in neonates, we can even measure bilirubin as well. So let's look at our basics in your acid-base balance, right? And what are the clinical applications where we can see them? So we know that acid-base is in our blood, right? So acids, it's a substance that dissociates into water to form hydrogen ions. And a base is a substance that accepts hydrogen ions. So our blood pH is maintained within very, very narrow limits to allow for normal cellular function. And this is really because our enzymes can only function with a very narrow pH range. And this is at a concentration of 35 to 45 nanomoles per liter. If we were to do a negative log of that hydrogen ion concentration, it would be a pH of 7.35 to 7.45. Right. So we take more acids than base in our foods, as you can see in this. There are more things on the acid side of the pH scale rather than the alkaline side. And this is also the same. This is the same internally. Our body produces more acids than base, right? So how do we then balance, right, such that our pH, our hydrogen ions are in that narrow range, right? So that is by being able to remove some of this acid. So volatile acids such as carbon dioxide can be excreted by a respiratory system, while non-volatile acids such as from your food, that all those that are produced endogenously can be excreted by the kidneys, right? Such that we are able to maintain an acid-base balance. Right. So we have this terminology called buffers, right? Buffers are substances that helps limit the change in your concentration of hydrogen ion or change in the pH in face of tendency to change. And this is through extracellular buffers, intracellular buffers, bone buffers, as well as the two techniques that we mentioned earlier, right? That is through excretion of carbon dioxide through the respiratory system, which allows for rapid response. And secondly, through renal hydrogen ion excretion, which takes a bit longer to allow for full response, and it's usually in the form of days. So the bicarbonate system is the most important buffer in our body. We have a very high extracellular concentration of base, and this base is in the form of your bicarbonate, right? And the base and the acid component being carbon dioxide, they can be adjusted. They are related through this equation that we can see here, right? Carbon dioxide together with water will form carbonic acid, and carbonic acid can dissociate to form your acid plus your bicarb. Right, and so we can adjust the acid and the base component to the left, right, through ventilation and removal of CO2. We can also adjust this acid and base component to the right of the equation through renal H+ excretion. And each components are currently able to be, we can measure them quite easily clinically. And that brings us to this, by measuring our pH, PCO2, and our bicarb levels, we can therefore identify various acid-base disorders using this Ziegler-Anderson chart, or also known as PCO2 bicarb nomogram. Right, if you look at the x-axis, that is your pH and arterial pH values. And remember, the normal ranges is between 7.35 to 7.45, right? And then we can look at the bicarb levels, which is the y-axis on the left, as well as the PCO2 level, the y-axis on the right. And by measuring the different levels, it gives us an idea of what could be, number one, is the acidosis, acid alkalosis in the patient, and secondly, what could be the causes, right? And just to run through a quick list of what could be the causes of respiratory acidosis. Now, this list is not exhaustive. This really happens when we have reduced ventilation, and it can happen in acute cases. It can happen in chronic cases where it's something more long-standing. Now, the converse is so anything that causes a hyperventilation can therefore lead to respiratory alkalosis, right? And then we also have conditions which can lead to a metabolic acidosis or a reduction in your bicarbonate, right? And this can be divided into a normal anion gap or a high anion gap cause, right? And by measuring the anion gap. So we can also differentiate the metabolic acidosis with high anion gap based on measuring and calculating the osmolar gap, and therefore allowing us to identify what could be the underlying acid-base disorder. Right. And we have also a list of, again, not exhaustive causes of metabolic alkalosis, right? So this brings us, therefore, to the clinical application of the arterial blood gas testing, right? So the one first reason for doing arterial blood gas testing is to identify what could be the current acid-base balance. Is it in balance? Is it in alkalosis or acidosis? And what could be the underlying disease that's causing this acid-base balance to be disrupted? The second reason for arterial blood gas testing would be to determine the oxygenation status of the patient. And the third indication would be in patients where they are on ventilation to assess the ventilation function. So therefore, if you think about these causes of acid-base diseases, oxygenation and ventilation status, this tends to be performed, arterial blood gas testing tends to be performed in places such as the emergency setting, emergency units, and the intensive care units, right? And we will go further detail about where, how, and who will be performing this, right? And that will be in our next part. So the specimen collection of arterial blood gas, we will look into what is the collection process, and what are the specimen volumes required, what are the devices that can be used, and then a little bit about Sharp's handling and efficient mixing, as well as pediatric blood collection. Now, coming first to who should or who can perform an arterial blood gas testing, right? So arterial blood sampling should only be performed by healthcare workers that have been prescribed the scope of practice for their position in their country. This varies from countries to countries and institution to institution. And secondly, it should only be performed after there is demonstrated proficiency all right, with formal training. So this table 1 that we can see here is an example of the list of healthcare workers in Croatia who are authorized to carry out specific procedures related to blood gas testing. And you can see that for arterial blood sampling, the Doctor of Medicine and Bachelor of Nursing are listed as the authorized healthcare providers to perform arterial blood gas sampling. And this at least in our current institution, we have doctors of medicine that are approved to do arterial blood sampling. But if the source of sample is from arterial line, then our Bachelor of Nursing are authorized to collect the specimen as well. Right. Then, before you start the blood gas collection, there is preparation needed. And first, most important thing is really a personal protective equipment. And secondly, the equipment needed for the blood gas testing. Right? This can be a pre-prepared or a commercial heparinized blood gas syringe or an in-house prepared one with your necessary bung or cap. And then the needles, disinfection, your gauze, shock container, and the pressure bandage or your other equivalent that's needed. Right? It is important to confirm the patient's identity with at least 2 patient identifiers, right? And ensure that the collection is done aerobically and aseptically. Right? If this blood gas collection is for the purpose of determining oxygenation and ventilation, after a change in the oxygenation and ventilation, then it is recommended to wait for 20 to 30 minutes before repeating a blood gas. Right? Then we look at what are the usual sites for arterial puncture. We can look at the radial, brachial, and femoral artery, and we will go into that next couple of slides. The selection depends on presence of collateral blood flow, the size, as well as accessibility to that particular site. And if a patient has an arterial line that has been inserted for closer blood pressure monitoring, then we can also do a specimen collection through the arterial line. So there is a need to assess the patient and look for any contraindications that prevent or for which cases we should not go ahead with the arterial blood gas collection. And this is because the arterial blood collection, it is definitely more painful and at a higher risk than a venous blood collection. There is a risk of arterial injury, arterial thrombosis, there's a risk of air or clotted blood embolism, hematoma, aneurysm formation, infection, nerve damage, right, and fainting and drop in blood pressure. So the contraindications to arterial blood gas collection includes if there is infection at the site, if there is a distortion of anatomy, if there is arterial venous fistula, if the patient has any coagulopathy or recent thrombolysis done, right? For example, if platelets are really low or if the clotting, the international normalized ratio is very high, or if there are peripheral vascular disease of the limb at the sample site, then these are areas that we should not go ahead with the arterial blood collection, or we look for alternate site. So where are the sites that we can do arterial blood sampling, right? So if you look at the picture on the right, the commonest site is our radial artery, which is at the wrist side. So if your palm is facing up, then it's the site that is further away from your body, right? That's where we call the radial artery, right? The next alternate site is the brachial artery, which is usually at the antecubital fossa or near the elbow region. And then the third site is our femoral artery that is in picture B, that is at the groin area. So the radial artery is the most commonly performed site. And before we perform arterial blood gas sampling from the radial artery, we need to assess the patency of the collateral, which is the other artery supply, which is the ulnar artery, right? Before we can go ahead with the radial artery testing. So let's just look at that patency of the ulnar artery is important because we want to make sure that in the event that there's an injury to your radial artery, the arterial supply to the hand will not be compromised, right? So how can we determine the patency of the ulnar artery? That is through this modified Allen's test. If you look at the picture on the right-hand side, So the picture on the right-hand side, right, you can see that first picture on the left, there is a plunged fist, and we can see a radial artery on the right-hand side and an ulnar artery on the left-hand side. So locate the ulnar and the radial artery for this patient, and then get the patient to make a tight fist, hold the hand in a tight fist for about 30 seconds, right? And then we will obstruct the blood flow by using your 2 fingers to press down the ulnar artery, and then 2 fingers press down on the radial artery, right? So then you get a patient to open or unclench the fist, right? And you will find that the palm should be whiter or blanched, right? If the palm is still nice and red, then it means that you're not applying enough pressure on the ulnar or the radial artery, and so you start again, right? So once you can apply adequate pressure on the radial ulnar artery and the patient's hand is blanched or whiter, then you release the pressure on the ulnar artery first, right? By releasing those 2 fingers that's on the ulnar artery. And if the hand flushes back, right, within 5 to 15 seconds, that is considered a negative modified Allen's test, and that suggests that the ulnar artery is patent, right, and it provides a good blood flow in the event that your radial artery is injured during the radial artery puncture. And so you can go ahead to do a radial arterial blood gas puncture. If when you release the ulnar artery, the hand still remains blanched, then that is a positive modified Allen's test, and it means that the ulnar artery circulation is not sufficient to provide for the hand circulation, and therefore we do not go ahead with a radial artery puncture. And that's when we consider the alternate sites, your brachial artery or your femoral artery puncture. Right, so then once you have done your preparation and you've excluded your contraindications, you have done your modified Allen's test to ensure that there is a good collateral artery supply from ulnar artery, then the next few steps are to describe the arterial blood gas sampling from the radial artery. So if you look at the first picture on the top right-hand side, you can see that there is a extended wrist, and there is a rolled up blanket or a small little like a pillow that you can put under the patient's wrist to keep the wrist supinated and extended at about 20 to 30 degrees, right? And if you look at this particular wrist, you can see some visible veins, purplish greenish veins on the surface, right? And remember to avoid inserting the needle through the visible superficial veins, because you will otherwise get a mixed arterial and venous blood sample, right? As the needle passes through the veins then to the artery. Right. And then number 3, assess the cause of the radial artery. Usually we start from the non-dominant hand when we start with radial artery puncture. And we want to assess the cause of radial artery first to determine where do you plan to perform the arterial sampling. Once you are satisfied and you're familiar with the direction and the cause for this patient, you clean the area where the needle is going in with disinfection. And then at this point, you can assemble the needle and the syringe if you have a commercial heparinized syringe. If you are using an in-house heparin syringe or in-house prepared heparinized syringe, then you may need a bit more time to assemble the syringe first, right? And once the needle and syringe are assembled, right, the next thing is the needle insertion. So if you look at the same picture, the top right-hand corner, right, the needle should be inserted at an angle of about 30 to 45 degrees. So this 30 to 45 degrees refers to the angle between the needle and the patient's wrist. And you can see that the needle and the syringe, all right, is held like a pen. Okay, so you hold the needle like a pen, insert the needle at about 30 to 45 degrees slowly until you feel a reduction in resistance and you see a rush of blood into the syringe, or what is known as splashback. And that can be seen in the second picture, the lower right bottom corner. You can see a little bit of blood, reddish blood in the lower end of the syringe, if you can see. And if you notice, right, the left hand is on the patient's wrist, and the right hand of this operator is holding the syringe like a pen. There is no no hand on the plunger, because if you are in the radial artery, the syringe will self-fill in a pulsatile manner. There's no need to pull the plunger, right? And so at step 8, fill to the required amount, and we will discuss a bit more about what is the specimen volume required. And then remove the needle once you are done and apply immediate firm pressure over the puncture site with some gauze. Right. The pressure application needs to be there for at least 5 to 10 minutes and even longer if there is other possible risk of coagulopathy. And you assess if the bleeding has stopped, and if it has, then apply a pressure bandage for about 2 hours. Right. So if a patient already has an arterial line for blood pressure monitoring, we can collect the arterial blood samples through the arterial line, and this needs to be done aseptically, right? And the second important point is that there needs to be a removal of excess solution and a clot. So if there are institutional guidelines for flushing of arterial lines and discard volume, please follow your institutional guidelines on that. If there isn't, then you can follow the guidelines of discarding of a minimum 3 times of the dead volume of the catheter. So you will need to know what is the manufacturer's specification for the catheter for the dead volume. And so minimum discard volume will be 3 times of the dead volume of the catheter. The reason is because if we were to just draw directly from the arterial line without discard volume, there is a risk of sample dilution. And so you may get a lower than expected PO2, a lower than expected PCO2, sodium, calcium, lactate, glucose, and hemoglobin. So after we have collected gone through the process, we mentioned, right, about the specimen collection volume. So I want to just share with you this interesting letter to the editor in 2016. And this is an interesting letter because the author, right, noted that when he was visiting a relative in an ICU of a medical institute in his country, he found the consultant doctors in the ICU discussing accuracy of the arterial blood gas report, and that they had concluded that most of the time the results were not satisfactory, right? And a month later, he himself had gotten himself admitted to the same organization, same institute, because of a renal calculi surgery. And he was in the ICU because of some post-operative complications. But he was obviously alert still. And he denoted that at the ICU, my arterial blood gas was done thrice. And to my dismay, all 3 times, the resident collecting my blood from the radial artery were unaware of the heparin to blood ratio. And then he realized that was the reason why the arterial blood gas results were not satisfactory. And so had prompted him to write this letter about sampling and steps for blood collection, right? So this is a common problem, I think, that we probably face, right, in different places. And so what would be the correct collection device and specimen volume required, right? So ideally, we should have a 1 to 3 ml self-filling plastic disposable syringe. And the use of lyophilized balanced lithium heparin is recommended, right? So sodium heparin is not recommended because it can contribute to falsely high sodium values, particularly if the sample volume is lower than recommended. Right. And the use of liquid heparin should be avoided because of risk of dilution effects on blood gas, as well as the fact that the heparin can bind to your calcium and give rise to your spurious calcium results. The other point to point out is that when there is improper anticoagulation concentration, right, as what the author has mentioned in the earlier letter that we went through, as well as insufficient mixing of anticoagulant and blood sample, you potentially can get erroneous results, right? So the other point is that different preparations of heparin by syringe manufacturers can also be a source of variability in your arterial blood gas results, right? Then what is considered optimum? Right, so CLSI recommended that we can have commercial preparations of heparin, right, especially if they are calcium titrated and electrolyte balanced. Right, in those cases, the they may even have a final heparin level of less than 3 IU per mil, right? So because these are calcium titrated and electrolyte balanced, right, they minimize the effects of calcium binding as well as the risk of clot formation, which is why heparin is needed, right, to prevent clots from forming. This has very little effects on electrolyte measurements. So therefore, if you have a calcium titrated electrolyte balance, heparin preparation can be up to 40 IU per mil. If you have a standard lithium heparin, then the recommendation is that the final heparin concentration should not be more than 20 IU per mil due to the potential effect on your lowering of ionized calcium. Right. So what happens if you prepare your own heparin syringe by using a traditional or using a normal whatever is a plastic syringe that's available in your institution, and you prepare the heparin yourself, right? So the recommendations from IFCC is that first you need to fill in the dead space of the syringe with heparin, and that is using about 0.3 to 0.5 mils of the anticoagulation aspirated into the syringe. And remember, you need to thoroughly lubricate the inner wall of the syringe, right? And once that is done, the excess anticoagulant is expelled, and it is recommended that the volume of blood that you collect in that syringe should be at least 20 times of the dead space or the dead volume of the needle and the syringe, right? The final heparin concentration to prevent interference on your measurement, such as your pH, your bicarb, base excess, and ionized calcium, should be what is in the table. So if you look at the table, right, if you have a glass container, a glass syringe, then the concentrations of final heparin in blood, it's higher than that in a plastic syringe. And secondly, if you use a dry heparin, the final heparin concentration can be a little bit higher than that if you're using a liquid heparin solution. So if we look at the third and the fourth row, where we are looking at a plastic syringe or plastic container, if you're using a dry heparin, then the final heparin concentration can be up to 50 IU per mil or 50,000 IU per liter. If you're using a heparin solution, liquid heparin solution, the final concentration should be maximum, in this case, in IFCC recommendations, up to 6,000 IU per liter or 6 IU per mil. Right. And at heparin concentration more than 15 IU per mil, the use of calcium titrated lithium heparin is necessary to compensate for this calcium chelation and to prevent increase in your sodium values. Right. So this is an interesting experiment where it looks at the percentage dilution ratios. Right. If we use different needle sizes, different syringe sizes, right, from 1 mil to 10 mils, which has different dead spaces, like IFCC have recommended. If you see from 1 mil to 10 mil, the dead spaces can vary from about 0.08 ml to about 0.2 ml, right, in a 10 mil syringe, right? And if you have different sampling volumes in each of these mils, you actually end up with different what we call final heparin concentration and a different percent dilution ratio. So depending on the syringe volume, depending on the needle size and the sample volume of the arterial blood gas that's been drawn, the final heparin concentration and percent dilution ratio can be variable and poorly controlled, right? And the important point to note from this study is that when there is partially filled syringes compared to fully filled syringes, there is a decrease in PCO2, potassium, ionized calcium, and an increase in sodium concentration that exceeds the total allowable error defined in the study. So the other point to emphasize, for if you're using non-commercial heparin syringes, meaning you are preparing the heparinization of the syringe in-house, the other thing about the heparin that's being used is that in some institutions, they would use the heparin that's being used for heparinizing the blood gas syringe. It is the same as that used for systemic anticoagulation. So that is defined as therapeutic heparin. And therapeutic heparin should not be used for anticoagulant for blood gas specimens because it has a very, very high concentration of 5,000 to 10,000 units per ml, which may affect your ionized calcium pH in the sample, right? So this is a tabulation of the differences in the commercial heparins compared to across in terms of the materials, in terms of the volume, nominal volume required, as well as difference in the kind of heparin that is used for commercial heparin syringes, right? Versus this is the one on the extreme the extreme right two columns are so-called in-house prepared heparinized syringes. And you can see that the concentration of heparin per liter of blood also varies across. Well, if there are so much difficulties or variables when you have to use heparin in the blood gas syringe, is it possible not to use heparin, right? Because we know intuitively that heparin is needed to anticoagulate the blood sample so that the blood gas analysis can happen, right? So this group in Japan, they tried to look at whether we can just use our usual plastic syringes for blood draw and for other purposes in place of dedicated heparin added syringes for blood gas collection. And this is a small study. They look at 20 patients in the intensive care unit who has the arterial line. So the samples were drawn by the arterial line. And the interesting experimental design is that they had collected the plastic syringes without heparin first, followed by 2 heparin-added dedicated syringes for blood gas analysis. And they look at whether there was any difference in terms of the parameters that were measured, right? And the other thing they have tried to do is that they have analyzed the plastic syringe, which is first drawn, the plastic syringe without heparin, within 3 minutes of collection. So when they compare these results from the plastic syringe compared to the heparin-added dedicated syringe, right, the measurements of the blood gas were generally considered acceptable, all right, as long as the plastic syringe is measured within the first 3 minutes of collection, right? And the second concluding point they noted is that regardless the type of syringe and the time of analysis, caution should be exercised in interpreting the results when measuring hemoglobin and hematocrit using a blood gas analyzer. So does this mean that we can do without heparin? It's probably going to be quite difficult to be able to complete your blood gas analysis within 3 minutes of collection. And so we probably have to, it's probably going to be something not feasible in most institutions. The next consideration is, right, is there a value for plastic syringes versus glass syringes, right? Because most places will be using plastic syringes, right? So plastic syringes can be used if the samples are analyzed within 30 minutes of collection. And this is based on CLSI guidelines, as well as you can see this study looking at the syringe material and storage time and temperature of blood gases and oxygen saturation in your arterial blood samples. And if the analysis is going to be longer than 30 minutes, then the recommendation is to use glass syringes. Right. So if you look at this table that we can see in this slide, right, looking at group 1 versus group 4, right? So group 1 is plastic syringe that's analyzed immediately versus group 4 that's a glass syringe analyzed immediately. There is no major difference between the two. And if we look at group 3 versus group 6, group 3 is plastic syringes that's stored at 30 minutes at room temperature, 22 degrees, defined as 22 degrees, versus your group 6, which is a glass syringe stored at 30 minutes at 22 degrees. You can see there is some difference in the PO2, the partial pressure oxygen, between that and the plastic syringe versus that in the glass syringe, right? And that's why there's this recommendation that if the analysis is 30 minutes or more, then consider sending a glass syringe. Right, so after the sample collection, right, it is important to emphasize sharps handling and labeling, right? So the needle should be removed with one hand, and because there is a needle used in this arterial blood gas collection, and that puts the person who is collecting specimen at risk of needle stick injury, there has been devices that helps to reduce this risk of needle stick, and that's what we call a stick shift, right? And this is through safety engineered syringes, and I've just listed 2 examples, but there are other available options. And remember to label the syringes with patient identifiers once the sharps is removed. So looking at one example of having sharps handling. So you have this syringe with a needle safety guard, which can be kept with one hand, right? So you can see this patient's left hand, right? It's pressing, the thumb is pressing down on the needle guard to cover the needle. And then thereafter, you can have a needle removal, right, with one hand, and then you can remove any air bubbles that's seen in the blood gas before attaching the cap, all right, or bung to the blood gas syringe. And then remember to label your syringe, right? So what is the fast with air bubbles, right? Immediately after the blood gas collection and just before analysis, right, we need to and expel any bubbles and put on the cap and the bung. This is because any exposure to the atmosphere, right, atmospheric air, can affect your pH, PCO2, and PO2, right? And if there is exposure of the arterial blood to the atmospheric air, and that is through air bubbles, right? It can generally increase the partial pressure oxygen towards 150 millimeter mercury, unless the patient is on supplementary oxygen, where you would expect the blood pH to be much higher than supplementary oxygen, in which case the blood O2, PO2 actually come down if there's exposure to atmospheric air. And for PCO2, because the atmospheric PCO2 is very low, when there's exposure of blood to atmospheric air, this will lower the PCO2 of blood and increase the pH of the blood. Then the next other important point to point out is efficient mixing. So after the blood is collected and before you're analyzing a blood gas, right, it is important to mix the arterial blood gas syringe in 2 axes. And these 2 axes so first one is the usual way of mixing of blood tube, which is up and down, right? So 10 times up and down, and then followed by your rolling, which is to rotate it 360 degrees around the axis of the blood gas syringe. The reason why we have requirements for mixing in 2 axes is because the mixing of the arterial blood gas syringe inherently it's not as efficient as that mixing of a regular blood tube, because there is no air bubbles in the blood gas syringe, and therefore the mixing tends to be a little bit less efficient. And so we need to mix them in these 2 axes 10 times in each axis. This is important to reduce microclots, which can affect your analysis. And the other important point about microclots is that they can lead to your analyzer downtime, right? So imagine if you have only one blood gas analyzer in the intensive care unit or emergency unit, then and you have a microclot, right? This will mean there is a downtime and you will not be able to measure your next blood gas sample, especially if there is urgent need to do so, right? The other than adequate mixing, the other way to reduce microclot is to collect arterial blood gas samples directly into a heparinized syringe instead of transferring from a plain syringe to a heparinized syringe, right? So this is a pictorial of what are the good examples of sample collection, and the good one is the one on the extreme right with the thick, right? Whereas the ones on the left, right, the first one, there is nothing, there's no blood in the syringe. The second one, there is a blood clot in the syringe. The third one, you can see an air gap between the blood level and the plunger, the syringe plunger. The fourth one, from the left, you can see small air bubbles, right? So the first 4 are all not ideal. The last one is the best. You have adequate field volume, you have no clots, no air gap, right? And no bubbles. So, challenging, right? The need to check for contraindications before we start arterial blood gas sampling, right? So because it's more painful, it's technically challenging. It can be done by selected healthcare workers. There is risk to patients as well as to healthcare providers. Then people have tried to consider whether we can do a peripheral venous blood gas sampling as an alternative, right, in selected situations. And a good thing is that we can do peripheral venous blood gas sampling for selected indications, right? First indication would be that in patients with diabetic ketoacidosis, where we want to identify whether they are in acidosis, we want to look for metabolic acidosis. There is a good correlation in such patients between the venous blood gas and arterial blood gas. So we can do a peripheral venous blood gas testing in cases where you're looking for diabetic ketoacidosis. Second group of patients where we can do a peripheral venous collection is in patients with chronic obstructive pulmonary disease, where we are looking for acidosis as well as any carbon dioxide retention. So in this group of patients, there's good correlation between arterial and venous blood gas for pH and PCO2, and we can do a venous gas collection, right? In the third category of patients where they have hypotension, they have acute respiratory distress syndrome, when you're trying to adjust the ventilation status, there is poorer correlation between the arterial and venous blood sampling, particularly for pH, PCO2, and arterial pressure or partial pressure of oxygen. So in this group of patients, we would prefer to do arterial blood collection, right, to give a better indication of the ventilation status. Right, and then in the fourth group of patients where you are assessing levels of this hemoglobin, such as your carboxyhemoglobin, your methemoglobin, you can do a peripheral venous blood gas collection as well. Then we also have scenarios where there can be other sample types drawn for blood gas testing, right? One scenario is a mixed venous blood sample that is obtained from the pulmonary artery. This is through a pulmonary artery catheter and is used to evaluate oxygen uptake and cardiac outputs. The second scenario is a central venous blood that can be taken so this is instead of peripheral, this will be a central venous blood sampling from a central line. And it can also be used as surrogate in selected situations. And when we look at the central venous versus arterial PCO2, the difference, right, when it's high, it does point to possible inadequate perfusion, such as in severe hemorrhagic shock in patients with poor cardiac output, or during cardiopulmonary resuscitation or after cardiopulmonary bypass. Right. Then in pediatric blood group and blood gas analysis, right, they are a little bit different because we may not be able to determine arterial blood sampling. And in this group of patients, the capillary blood is considered an adequate substitute for arterial blood in neonates and pediatric units, right? So there is a need to assess for adequate perfusion at the site. So you would prefer to sample from a site that's well perfused, right? And before the capillary blood taking, right, we can do what we call arterialization of the capillary site, right? So usually capillary site would be either at the heel or the fingers. And how we can arterialize the capillary site is by warming the area to about 42 degrees before obtaining the capillary blood. Now, we do not recommend squeezing or milking, right? So after making a single deep puncture, allow the blood droplet to form before collecting the blood from the center of the droplet, right? And capillary collection can be facilitated by use of narrow bore tubes that we can see on the lower right-hand corner. So when collecting these capillary blood samples, we do not recommend strong repetitive pressure or milking because the process of milking can lead to hemolysis of the blood gas sample, which can be problematic if you're looking for electrolytes measurement. And second potential problem is that there can be contamination of the specimen with the tissue fluid as well. So that can lead to a dilution of the analytes of interest. All right, and once the sample has been collected, right, the next step is to decide, right, how do you want to send this to the laboratory, right? If there is no blood gas testing at the emergency site or intensive care site or in the general ward setting, right? So based on CLSI, hand carrying of a blood gas sample has minimal effects on the blood gas and pH results, even if some small air bubbles are present. And what about pneumatic tube transport, right? We know that pneumatic tube transport is very useful and convenient in allowing us to send samples to the lab at a faster pace, right? So if there are small air bubbles present in the blood specimen, the process of pneumatic tube transport can lead to equilibration of the air bubbles, the atmospheric air and air bubbles with the blood, and therefore have a noticeable effect on PO2, particularly less on PCO2. So if we think about the process of collection and the fact that we emphasize on removing air bubbles, right, and then putting the rubber band cap on the blood gas syringe, then assuming that that process has been checked, then it is safe to send the sample via pneumatic tube transport, especially if we are looking at saving time and saving resources in terms of transportation of the sample to the laboratory. Then the other component of specimen transportation is, do you send the sample in ice or not? Right. Intuitively, we know that when the blood sample is taken out of the body, there is still ongoing metabolism by the cells, right? Your red blood cells and your white blood cells. So as you have ongoing metabolism, you may actually lead to continued utilization of oxygen, right? And as well as the continued production of carbon dioxide. And therefore, people believe that we send the samples in ice so that we can stop or reduce the metabolism of your red blood cells and white blood cells. And so-called preserve your oxygen and your carbon dioxide levels, right, before the analysis is done, right? So, but however, there has been additional information or from studies that shows that when partial pressure oxygen is stored in blood syringes, right, they change over time, particularly and perhaps when the blood is stored at 0 to 4 degrees. And the hypothesis is that when the blood syringe, right, blood is stored in a plastic syringe, and when the plastic syringe is cooled to 0 to 4 degrees, the plastic molecules contract. And so this leads to bigger pores for oxygen to move through and equilibrate, but not so much for the larger carbon dioxide molecule to diffuse through. So if you look at this table on the right-hand side, it looks at the partial pressure of oxygen, right? And this is the same study that we looked at earlier, right? We're looking at glass and plastic syringes. So if you look at group 4, 5, and 6, right, in the glass syringes, interestingly, whether they analyze immediately or analyze after 30 minutes at 0 to 4 degrees, compared to at 22 degrees of room temperature, the change in the partial pressure oxygen is not significant, right? That can be contrasted against your group 1, 2, and 3, your plastic syringes, right? Where group 1 is a plastic syringe analyzed immediately and so-called the baseline of the reading, compared to group 2 and group 3, where the plastic syringe are stored at, they're analyzed after 30 minutes at 0 to 4 degrees for group 2 and room temperature of 22 degrees for group 3, you can see that the partial pressure of oxygen actually go up, right? And in this case, there is no big difference between that of the syringe stored at 0 to 4 degrees and that stored at 22 degrees. So the CSI recommendation is that plastic syringe should not be kept in ice, but at room temperature, as long as you can analyze the blood gas within 30 minutes of collection. And the reason for not recommending transportation of sample in ice is because of the hypothesis that the plastic syringes are more permeable to gases at lower temperatures. And also, the second important point is because of risk of hemolysis, right, when the sample is placed in ice. And there are other studies that shows that oxygen and carbon dioxide levels in the blood that are kept at cool room temperatures at 20 to 30 degrees, they're less or minimally affected, except in presence of cases where patients have very high white blood cell leukocyte count or high platelet counts, right? So in patients where you have very high white cell count, white platelet counts, or in patients where you're doing special studies, such as arterial, alveolar, AA, oxygen gradient, or shunt studies, then the blood sample should be analyzed as quickly as possible and preferably within 5 minutes of collection. Right, so for blood gas samples for other patients, if a delay of more than 30 minutes is anticipated, then recommendations store in glass syringes and in ice water. right? So this is a very recent publication looking at the stability of blood gases and oximetry under slush ice in room temperature. And they have done a tabulation of what could be the analytes that should be reported and the so-called recommended allowed storage time. Right, and you can see that depending on the analytes of interest, the so-called allowable storage time is different in room temperature and in slush ice, right? And so the summary of this would be that depending on what analytes are you testing blood gas or blood gas together with electrolytes, with lactate, all right, then you can do an individualized decision to decide whether the icing should be sent together. Right, if you are doing an analysis for electrolytes, particularly potassium, and the samples are stored in ice, there may be this transcellular shift between cells and plasma that can lead to erroneous potassium. On the other hand, if you're measuring lactate, right, in absence of anti-glycolytic agents, the lactate samples, the lactate concentration will go up, and so the analysis should be done within, as soon as possible, within 15 minutes of collection, right? And then after blood gas analysis, right, a quick review of the results actually will be useful to look for whether there is inconsistent results compared to the patient's past results in condition. If there are internal inconsistencies or if they're extreme of results. The reason is so that you can decide whether you want to reanalyze specimens with questionable results so that you can retest and confirm. Otherwise, the quality of the specimens deteriorate rapidly, as we have seen earlier, right, within even 15 minutes, depending on the analyte of interest. And so you will not be able to verify the findings thereafter. Okay, this last part about point-of-care testing versus laboratory testing. So we've gone through a little bit about history of the blood gas analyzers coming initially from individual PO2, PCO2, and pH electrodes to having a combined automated instrument that allows you to use individual biosensor technology, which can be replaced individually, to current newer benchtop analyzers that has sensors that miniaturized into one microsensor cards, and even things like QC solutions and calibrators in separate individual replaceable cartridges that can even do self-verification and automatic QC testing, right? So this can be contrasted against cartridge-based point-of-care testing, where everything is in one cartridge, all in one cartridge, right, which allows for easier use. They are usually handheld or smaller. They can therefore allow for use at the bedside or even in case of ambulance or off-site places. And any issues with electrolytes can be solved by replacing the entire cartridge, by using a new cartridge. So the considerations for using a point of care versus a laboratory benchtop would really depend on cost, connectivity, the training and user ease of use, as well as availability factors. Right. So the take-home messages from today's sharing is that first, arterial blood gas testing can be done in emergency and ICU settings, particularly when we want to determine acid-base diseases, oxygenation status, and ventilation changes. It should be performed by trained healthcare professionals, and consider venous blood gas testing in selected scenarios such as your diabetic ketoacidosis in patients with chronic obstructive pulmonary disease, in cases where measuring carboxyhemoglobin and methemoglobin. And pay attention to the common errors, right? Especially first thing that we looked at, the adequate sample specimen volume to happen ratio. Remember, adequate mixing in 2x 10 times, and removal of visible air bubbles. Yeah, with that, thank you so much, everybody, for your time and attention.
Thank you very much, Dr. Ong, for that very insightful presentation. We did have a few questions sent out during the presentation. So let me just read it out for you. So the first question we had is that, if we are able to collect blood gases sample collection together with other blood tests. So for example, if patient has some blood tests that are required and was collected through arterial blood to test for renal function or FBC, and blood was collected in 20 cc syringe, are they able to distribute into pre-heparinized syringes followed by all the evacuated tubes for those testing? So what is actually the best practice for specimen collection in this kind of situation?
Thank you so much, Nadra, for summarizing the question. So if we can go back to, let me just go back to the part about efficient mixing. So sometimes we do encounter situations emphasize, right, where you are collecting arterial through the arterial line, multiple samples, including blood gas analysis. So most rational approach will be collected through, for example, a plain plastic 20cc syringe. But remember to transfer it as soon as you can into a heparinized syringe for the blood gas testing. The other alternative is if your blood gas analysis, your blood gas testing allows for testing for electrolytes, then that will allow you to just collect into one heparinized blood gas collection to be able to test, for example, for your electrolytes. But I think the question is probably thinking about even things like creatinine and even things like other analytes that are not currently available for testing on the blood gas analyzers, then yes, you can collect it into a bigger syringe and then transfer it. But then remember, the transfer is associated risk of needle stick injury, and also it needs to be done as quickly as possible to reduce the risk of microclots.
All right, thank you, Dr. Ong, for addressing that question. Unfortunately, due to the time constraint, we will actually need to conclude the webinar very shortly. However, rest assured that any questions that you have will be addressed via an FAQ that will be emailed within 2 weeks. We would appreciate your feedback on this session, and we hope you will complete the survey form upon exiting this webinar. Once you have completed the feedback, a certificate link will be emailed to your registered email to be downloaded. Once again, thank you so much, Dr. Ong, for the lovely presentation, and thank you everyone for making the time to attend this session. We hope you enjoyed this presentation and look forward to seeing you at the next webinar on the 25th of October.